now, you should have a little option pop up on your screen if you're happy for the lecture to be recorded. Just to reassure you, you won't be in any of the shots at all. It will just be myself and Rob who will be filmed. But if you're not happy being in the session when it's recorded, we'll have to ask you to leave, unfortunately. Feel free to submit any questions that you have throughout the lecture, and Rob will be checking them throughout and responding to them. I'm anticipating that we're going to have quite a lot of questions, so my apologies in advance if we don't get around to all of them, but I will put our email address up at the end, and we can answer any burning questions you have if you forward them on to us afterwards. Also, if you're having any technical difficulties for any reason, feel free to post them in the chat and we'll do our best to help you remotely. Great. I think that is everything housekeeping wise, so I'll introduce our speaker for this evening. So Dr. Rob Galloway is a consultant in emergency medicine and dual trained in ITU, intensive therapy unit, but as he has the concentration span of a gnat, he realised he couldn't carry on working in ITU. His medical interest is in human factors and cardiac resuscitation. Away from NHS work, Rob leads for undergraduate emergency medicine education at Brighton and Sussex Medical School. He is the lead crowd doctor for Brighton and Hove Albion Football Club. He's the medical director of the Brighton Marathon and writes newspaper columns, and also wrote a book about working in A&E called A&E in Stitches, The Highs and Lows of Life as an A&E Doctor, under a pseudonym Dr. Nick Edwards. He has led on developments to improve patient care, junior doctor retention and training, and has helped set up a roster system which is now used in over 50 other hospitals. Apart from work, he plays five-a-side football badly, supports Leyton Orient Football Club, who play badly, and Brighton and Hove Albion, who play well, and once had a few shows as a stand-up comedian, which ended up badly, so he went into medicine. He used to have a social life and personality, but now has 3 young kids and runs a taxi service. So following that slightly self-deprecating introduction, let's all welcome Rob Galloway. Thank you.
Thank you very much for coming in this weird virtual world. When I'm talking, please, if there are any questions, please go onto the chat function and chat and say, ask any questions. At least then I know people are there. So very kindly, I've been asked to talk about what it's like working in A&E over Christmas. And say, my name's Rob Galloway. You can see my email and Twitter and all that lot. But just before we start, I want to talk about why we're doing this, really. It's part of the Brighton and Sussex Medical School widening participation to medicine programme. It's something that I'm absolutely passionate about because, say to a lot of my colleagues, to a lot of our medical students, doctors aren't people I work with, in all honesty. And often the thing which makes people the best doctor is if they come from wide, diverse backgrounds. We don't want identikit people going into medicine. And so I'm absolutely passionate about this participation program. I'm delighted to be able to speak. And hopefully I'm going to give you an insight on what it's like to work in A&E and why you may want to go into a medical or nursing or anything like that career, because I genuinely think it's a fantastic thing. Just a little bit about the Brighton Medical School outreach program. You can read that. It's there to try and encourage diversity amongst who we recruit into medicine. So please, I remember my partner saying to me that she didn't think that when she was at school, she had someone from Birmingham Hospital saying, unless you've got 9A stars at GCSE, you've got no chance of getting into medicine. And that's just complete rubbish. It's absolute rubbish. We really want people to come into medicine from a diverse background. So please have a look at their the stuff they do and their widening participation to medicine course that they run. And also, if you're in Sussex, it's have a look at the BrightMed course which they run for students in Sussex. Right. So that's just a little introduction to why we're here. So essentially, what's it like working in A&E? Well, in all honesty, this is my 19th Christmas as a doctor, and last 10 years I've been a consultant, which basically means I'm exactly the same as a junior doctor, but a bit more scared because the responsibility lies with me. But we still need to cover Christmas like any other day, and I estimate about 50 to 60% of Christmases that I've worked, and this Christmas Eve I'm working again, and that's right because our patients come all the time. We don't get people not on Christmas Day. Just, it's not like an elective operation list or a GP surgery where you go with minor concerns and stuff. This is happening all the time, and it's exactly the same 365 days a year. So if you're going to be working a random Thursday, you're going to have to work on Christmas Day as well. Why isn't it that bad though? I actually think it's quite a good job, really. You can see the slide there. If you work in the NHS, you know, whether you're a GP because that's such an important job, or whether you're an A&E doctor, or a geriatrician, or whatever, being a doctor, I genuinely think it combines four great things: what you love, what the world needs, and you know, never before have we needed as many doctors and nurses and everything as we've got now. What you're good at, and actually, especially if you go to BSMS, we train you, I think, very, very well. And we're incredibly lucky, more so now, because it is the most reliable job. You're never going to, you know, we're never going to be furloughed. What pays well, and it gets that absolute beauty spot of it. It's what you love, what the world needs, what you're good at, and what pays well. And it's really, really something, you know, every job in medicine, I think, fulfills those four criteria. And I say, I'm a generalist, and I think there's only three generalists: A&E, GPs, and we're the other side of the coin of GPs. We've got the same skill mix. I think we're, you know, the GPs are probably the most important part of the NHS, then followed by generalists such as care of the elderly and A&E. But we are, you know, our jobs fulfill those needs. And what's it like? This is, I'm sure some of you have seen Casualty, where the doctors are never stressed. They're beautiful and everything goes perfectly, and they say shocking really, really loudly, and everyone survives. Unfortunately, that's not A&E at all. Then we've got ER. There's George Clooney, who I think probably looks very, very similar to me. I'm not sure if that's true. Again, it's not really like that. What it's probably like is a bit like this. You can see the some of the mayhem, but it's about working in very, very challenging situations. And this is only from a couple of years ago. This is actually from, I think, from this isn't from Brighton, but that is seen from an A&E department. So what's my role? My role is in A&E. I'm overall a manager. I'm a teacher, but on the shop floor at work, I'm a team leader. So it's about trying to create order from the chaos of what's going on. But first and foremost, and the most privileged thing I do, is I'm a clinician. I'm there looking after patients on a day-to-day basis, and Christmas Day being exactly the same. And it is an absolute privilege, but with great responsibility, our job as doctors. And it is something that, although it's been a stressful 19 years and there's been highs and lows, it has been, you know, it's something I wouldn't change, and I would do again if I had a choice. But the other great thing about working within the NHS is you're working within a system which is different to any other system in the world. In the NHS, you know, I've got American colleagues and friends who work there, and we practice in trauma a CABC, circulation, airway, breathing, circulation. So you're stopping any massive bleeding, then you look after the airway, then you look after the breathing, then you look after circulation. In America, that CABC is credit card, airway, breathing, circulation, which is not the way I want to work. I want to look after a dustman from Bromley in exactly the same way as someone with caviar choking and silver spoon hypoxia from Putney. You know, it is wonderful that the NHS allows us, and I'm incredibly fortunate to work in an NHS where everybody is treated the same, and you're treated on basis of need, not wealth. So how do we look after our patients? Well, everyone thinks you just go to medical school, you learn a load of facts, you spend 6 years cramming a load of facts, and then you can become a doctor. But it's actually, to look after our patients is really quite complex. And there's 5 key parts to it. And you can't be a doctor and you can't look after patients unless all 5 elements are there. And the first element is technical and knowledge. So I've learned how to treat the conditions I'm going to be talking about in this talk. I've learned how to understand the physiology of it and know what to do. But that's only one of the 5 pillars. Secondly is compassion. I genuinely don't think you can be a good doctor if you don't care passionately about your patients. Sadly, there are a few people who've gone into medicine because that's what they thought they should have done, or they've gone into for the money. You certainly wouldn't go into A&E for the money. I just genuinely think unless you're compassionate about what you're doing, you cannot make a good doctor at all. The next thing is your non-technical skills, which people don't really know what it means. It's about how you don't make mistakes and work as a team. And we're going through that a little bit. The fourth key thing is resources. Absolutely need the resources to be able to provide that care. And the final thing is interpreting the evidence and knowing how to treat what we do, because 50% of what we teach our medical students is wrong. We just don't at the moment know which 50%. I remember last year I was giving a lecture, or this time last year, saying if someone comes into any, you try and rule everything out. If there's nothing to worry about and there's no signs of bacterial infection, you can reassure the patient that it's just a virus. The days of just saying we can reassure the patient it's just a virus, I think, have long gone. Similarly, we're talking about COVID. The two best treatments now are dexamethasone and antivirals. Now, dexamethasone originally was contraindicated and said you cannot give it in COVID because that's what the teaching was, but only because of new data and new studies have shown that actually it's life-saving. So those are 5 key things that we need whenever we're looking after patients. Okay. And so I want to use those, when I'm going to be talking about what it's like to work in A&E over Christmas. And I thought, well, I can either give a lecture, which I'm sure a lot of people go to lectures, and it's, lectures are great if they're face-to-face, but it's quite difficult trying to get over the enthusiasm on a Zoom talk. And I thought, well, it's Christmas as well. Being asked to talk about what it's like working at Christmas, I'll do it through interpretive aspect of dance, not dance. That wasn't a mistake. I'm not going to be dancing, through song, and hopefully you'll like the song. I don't know, but maybe you'll sing along with it, and hopefully by singing along to it, we can try and understand some of the things we do in A&E, and you can understand what a day is like in A&E. Now, all these patient stories are taken from different days of the last 19 years. Obviously, it's not just 1 year, but these are things that happen over Christmas. So I know things are working. Please, anytime you've got any questions, I can see if you've got questions, please don't put them on the Q&A, put them on the chat. I'm just really worried. It said my internet connection is unstable, so I'm a bit worried that it's can someone just type they can still hear me, because that would be really worrying, because my internet's just come and said it's really unstable, but no one's typing. Is anybody there?
We can hear you, Rob. You just cut out briefly, but we can
okay, fine.
Hear you now.
So it's back there. Brilliant. Cool. So I'm just going to go through the song, and then hopefully you can sing along, and then we can try and go through some things. It's called the 12 Days of A&E-mas, which I'm sure you can take as being obviously it's taken from the 12 Days of Christmas. My singing is not very good. I apologise. On the first day of Christmas, my true love sent to me a patient in A&E. Sorry, that was absolutely dreadful. I just want to talk about this case, because to me this personifies everything that we try and do in A&E and all the stuff which is important. This was actually the family are very happy. This isn't breaking confidentiality in any way, because the family have given us our permission to talk about this. I've talked about this case a number of times. This was just before Christmas. This was just before Christmas, and 6 years ago now, a 14-year-old lad came off his push bike whilst delivering his Christmas round of newspapers, and he came into A&E in a very, very unwell state. He was knocked off his bike, and he was intubated, which means we put him to sleep pre-hospital. And we set up in the last few years these checklists, which sound a bit dull, but basically they're systems to make sure we don't make mistakes. And it's copying from the airline industry, and that. Using that, he was successfully intubated by my pre-hospital colleagues, basically intubated, taking over the breathing. Then on arrival, had low, what we call saturations. We need to suction out some of the secretions from his lungs. He then started to cough, but we had all the treatments for it. And we sent him to CT scan, which showed he had intracranial injury, and he went up to King's 10 days later. And he was discharged, but he came back 10 days later very, very well, and no ongoing medical problems. And that's the newspaper clipping from he came back on Christmas Day. Came back home on Christmas Eve, and this is on Christmas Day. And that's his mum and his dad. That's me with my dreadful hat, and one of my very good friends, and one of our A&E sisters. And that's the young lad. And the dad said to me, and I was trying to explain to the dad, saying, what you may experience is your son will get, after the brain injury, will get some mild personality changes. And Dad was like, oh, it's absolutely wonderful. He's such a nicer bloke since his head injury. So it just shows that, if he hadn't have had the treatment he's had, this child would almost definitely have died. But because of the treatment from pre-hospital to hospital, he survived. And 10 days later, he came back really, really well. So that is, in terms of, in a nutshell, why I work in A&E. And so Helia has asked, why did you choose to go into work in A&E? that picture, I think, explains why anybody would want to go into A&E. It's an absolute privilege to be able to go and try and look after kids like that. So, you know, do you find it's just going through the question from Helen? Do I find it stressful? Yes, but in many ways, I know it sounds weird, your training makes you relaxed. So the most relaxed I am in life is actually when I'm standing in front of a team of 9-10 people and a critically unwell patient, because you just follow protocols and you go down a path of what's standard ways, the standard operating procedures, and actually it's very it's a safe place. It sounds very weird. I find the management I do and the organisation of the politics of trying to sort out problems at work stressful. In terms of looking after individual patients, that's just you don't learn to cope with stress at all. You get techniques, but the only way of learning to cope with stress is just you learn standard operating procedures and it becomes your comfort zone. So that is the first thing. If I don't answer your questions going through, there's a number of cases I'm going to be going through, so I apologise, but just to answer them as I can. So in terms of Christmas with my family, yes, I love being with my kids, absolutely. I want to be with my family, but you also need to realise that you get other time off, but also I'll work a late shift, for example, and have the morning off. So this year, I'm with my partner, we're working nights over Christmas, finish in the morning, Christmas morning, and then the kids come over at 3 o'clock. So it's not too bad at all. It's wonderful. Okay. What I'll do is I'll come back to some of the questions in a bit. Okay. And we'll answer more generic. So if you've got questions specifically about each case, please ask them as we're going through. If you've got questions more general, like how many hours a week do you work, etc., and how do you deal with patient death, just ask them towards the end. That's probably the best way of doing it. So this case was all about, you know, it wasn't a particularly special case. We didn't do any amazing science or anything like that, but it was just safe teamwork and human factors, making sure the basics were done correctly. And that's what made the biggest difference. That's why that patient survived. And that's why I was so proud of it, because it was just, in some ways, it sounds awful, but it's a standard case, but it made such a big difference. On the second day of Christmas, my true love sent to me two latex gloves and a patient in A&E. I've got no idea if the singing was the right idea. It's really hard to actually get any idea with everybody being on computer. I'm sorry if the singing's embarrassing, but never mind. So there's a couple of latex gloves. Anybody know why we specifically use latex gloves? Which part of an examination would you use latex gloves for? Oh, thank you, Claire. That's very nice. You love the singing. But basically, it's when we're examining. Does anybody know, just on the typing, if anybody know what that would be used for? Yes, from Trunk for rectal examinations. Does anybody know what that is? It's not colonoscopy. It's close. It's a rectal temperature probe. So this was a very, very sad case from about 4 years ago. An 87-year-old gentleman came in hypothermic, which is just low temperature, and basically he couldn't afford the heating. And he presented, you know, because he couldn't afford the heating, and he basically got really, really cold and then became unconscious. And the police had to break into his room, and a neighbour called him in sick. And we had to do rectal temperature, and we found his temperature was down to 32 degrees, and he got better whilst we treated him. Yes, all these cases are ones I've worked on myself, Alex. Yes, and so it just shows that poverty is a massive contributor to patient outcomes. And if you look in the UK, there's about a 25-year life expectancy difference from those in the who live in the richest postcodes, those who live in the poorest postcodes, showing that although what we do in A&E is crucial for patients' outcomes, actually what may make a bigger difference to people's lives actually is the political side of it, and really trying to change society for the better. Because this gentleman did not need to come. If he could have afforded his heating, he wouldn't have come to A&E. On the third day of Christmas, my true love sent to me 3 fractured ribs, 2 latex gloves, and a patient in A&E. Before I go into this, Holly asked the best questions, you know, really, what happened after their treatment, such as being offered heating by another service. After he was treated, we got him social workers so that he didn't so he was managed, and there's lots of societies and charities and public health to help him. So 3 fractured ribs, 2 latex gloves, and a patient in A&E. So this was a gentleman. You can see the X-ray there, or an image of the X-ray. This is a gentleman who'd basically come off his push bike, and he walked into A&E, and you can see that the fractured ribs, and the ribs surround. I don't really care about the ribs. What the ribs do is they protect the lungs. But unfortunately, he got this X-ray. This is an X-ray of his. We diagnosed this clinically because you shouldn't ever take this X-ray. But what you can see on the left-hand side is I'm just going to see if the annotation is lung markings. The white there is lung markings. Does anybody know why that's black? What might have caused that to be black? That area there. Fluid, good idea. Pneumothorax, Lucy, correct. Okay. Wow, the number of answers. So on the left, on the right over there, let's just get on the right over there is lung markings. Is lung markings, and on the left is something called a pneumothorax, which is where the air has got into the between the lung and the ribs, and that's really, really quite dangerous. And that then compresses the lung and pushes the heart over, and the heart shouldn't be over where it is. It should be right in the middle. Now, so the white is the normal bit of lung, the black is the pneumothorax. I'm just struggling to take off this annotation and move the next slide.
There should be an option at the top of your screen, Rob, to clear the annotations.
Oh, this is embarrassing.
No, that's okay.
Clear all drawings.
Yes, that's
perfect. Fine. And then can I then do next slide? Oh, I can't do next slide. Sorry, this is
right. Have you tried? Can you click on the slide? Maybe we use the arrow.
I might. It seems to have crashed. Oh, clear all. Sorry about this. So, can you try and talk that? So the way we treated it was we had a lung marking. So you had the lung. I've got someone trying to sort this out. So you've got your lung, and it was being compressed by air which has broken through from it's sucked out from the ribs. The ribs are broken into the lung markings, into the lung, and it's sucked in between the lung and the rib cage, and that made it impossible to for air to come in normally, and it started to compress the lungs and started to compress the chest. And so what we did is we used a chest drain to open it up and released it, and it literally, he went from being so short of breath and thought he was going to die to suddenly being able to be completely fine. I really am struggling to try and get this to stop. I just can't move the slides.
Rob, we've had suggestions that you might still be using the annotate button. You might have to stop annotating yourself.
Yeah, I don't know how to do that.
Clear and then X.
I'm trying to press clear. This is escape. I just seem to have lost.
You can stop sharing your screen, Rob, and see if you stop sharing and then go back into it. That might help.
I'm trying to stop sharing as well. I'm not. It seems to.
It's clear.
I can't even stop sharing. It seems to just crashed my computer by.
I can manually stop you sharing, Rob. Would that be helpful?
Yes, please. And then, right, and then if I go back to share. Yes, perfect. I don't know what happened then. I apologise profusely. It shows my ineptitude. So this is the tough thing, which this is something. Oh, now I need to get back to the chat function. I can't get. Chat screen. Cool, lovely. Sorry about that. That's just it's modern world. I'm useless. So we need to put in a chest drain, but initially you can put in something called a needle decompression, and basically we put in this needle, and we could just see him just going from being short of breath and about to die to the air being released and him surviving and feeling so good. It was an amazing thing to witness. Apologies about my lack of IT support. I apologise. On the 4th day of Christmas, my true love sent to me 4 shocking pads, 3 broken ribs, 2 latex gloves, and a patient in A&E. And there is the shocking pad. So this is a defibrillator. Does anybody know what a defibrillator does? Just some answers on the bottom. Anyone know what defibrillator does? Okay, so yeah, absolutely. So it restarts the heart. So it restarts the heart. And does it work? So let me just tell you a little bit about defibrillation. So defibrillation is when someone, whilst we've got a lot of people here, if you ever see someone collapse, okay, and the first thing to do if you ever see someone collapse is go and see if they're dead or not, okay, and basically scream, squeeze their muscles, put your head down to their ears and listen to see if there's any signs of breathing and a pulse, and you'll either find out a patient's dead or alive, okay. If they're dead, that's great, it's really easy to treat. If they're alive, patients are problematic, okay, and then you've got to know what to do. But if they're dead, it's really simple. You start CPR and just press down about 100 beats per minute, which is literally staying alive, staying alive at the center of the heart. You can do no wrong, and you get an AED. Okay, that is what saves lives. And Brighton has got a lot of history about AEDs and about defibrillation. I'm very proud of what we do at Brighton. So the first ambulances in the world to carry defibrillators were Brighton in 1971. You see these, maybe that's tacky. I don't know if they're dead. That's great. That's probably, it's probably awkward. We can't edit this. I didn't really mean it's great they're dead. It's like it's easy because you just follow a protocol. So please don't take that to as in literally it's great they're dead. No, it's obviously not great they're dead. It's good as long as you realise it's stroke. Anyway, so the first AEDs were. Anybody know what an AED stands for? I'll leave that for people to answer. But an AED, the first AEDs were developed in Brighton, okay? And we had them at Brighton Railway Station and Victoria Railway Station because it was a line down from, it's automated external defibrillator. And it's a line down from Brighton to London. And they were the first in the world at Brighton. And the first ever paramedic practitioner was in Brighton. And the first professional responsible for training resuscitation was in Brighton. And this is a paper from one of my friends, Professor Chamberlain, who's a hero of Brighton. And he brought in the first ever paramedic and paramedic ambulance containing a defibrillator. And I'm actually at the Amex Stadium tonight. I'm not sure if you can see that. This is where I'm meant to be tonight. So we see that. That's at the Amex Stadium. I'm there because I'm the crowd doctor. But before the Amex Stadium, does anybody know where we used to play? Obviously the answer's on the screen, so I know what I've asked. It's at Goldstone Stadium, and also there is 2,000 people. There will be 2,000 people for the first time in ages. So we used to play at the Goldstone, and it was famous for 2 things. It was famous because David Beckham had his first professional debut as a professional player there when he played for Preston on loan, and but it's the first stadium in the world to ever have a defibrillator. Okay, which is unbelievable that Brighton was at that case. And again, this is the paper describing it. What about now? This is the Amex Stadium where we are now. And we've actually had, since 2011, 6 cardiac arrests. And normally, you've only got a 1 in 20 chance of surviving a cardiac arrest. But because, survive them to, good neurological outcome, or what we call it, season ticket holder status. And this case wasn't actually from Christmas Day. This was from Boxing Day. So I was at the Amex, and a gentleman got very excited from the match. He's in his late 70s, and he had a cardiac arrest. And we've got such a fantastic system with the St John ambulance. I work alongside the St John. I'm very, very proud to work alongside St John, and I work alongside them. They did first aid. They started CPR. They actually did the defibrillation. They got him back. I was there, just there to support. And they were absolutely brilliant. And so I then managed him, and he had some really difficult arrhythmias after, where the heart was going to different rhythms. And I gave them a drug called amiodarone. And I was taking him down from the Amex Stadium to the hospital, and he started to wake up, which was wonderful. And anybody know what his first question was that he asked? Any guesses? Exactly, who won? We were 1-0 down. We're winning 1-0 when he had his cardiac arrest. I didn't want to tell him, but we lost 2-1. But you can see that he survived, and we've had 6 out of 6 have survived at the Amex Stadium because of 2 things. One is CPR, and CPR done by anybody saves lives, okay, and also defibrillations, and the cardiac defibrillators make a massive difference. And this was our paper looking at those recent cardiac arrests and how we've done a very good service for the people of Brighton at the Amex Stadium. On the 5th day of Christmas, my true love sent to me 5 broken bones, 4 shocking pads, 3 broken ribs, 2 latex gloves, and a patient in A&E. Very good question, Helia. How do you know how to shockable rhythm? Well, just going back to that last case, the automatic external defibrillator can tell you if it's a shockable rhythm and will shock it if there is one, or we have our posh defibrillators which we can assess the rhythm and decide. But it's a really good question. So this is a typical case. This is I remember this case because it's Christmas Day. A 25-year-old patient was trying to get. This isn't that exact ankle. Was trying to climb on the table to try and get to he had a very big house. He's trying to get to the top of the Christmas tree. He slipped and his ankle looked like that, and that was the X-ray. What we do in those situations, we sedate them. So that's both it's a fracture and a dislocation, absolutely. So we sedate them in a safe environment, and then we can pull those ankles back, and then they need to go to theatre to be fixed. But again, it's something as an A&E doctor, you don't do the operation, but you do the initial fixing, and that's really, really satisfying. It's a great thing to be able to do. On the 6th day of Christmas, my true love sent to me 6 mums are laying, 5 broken bones, 4 shocking pads, 3 broken ribs, 2 latex gloves, and a patient in A&E. This is a case I want to talk about because although it was a couple of days before Christmas, I wasn't involved in this case, but one of my friends was, just because it's so traumatic, but what happened, but such an amazing outcome. So this was a 29-year-old lady who started to complain that she was 8 months pregnant, and she started to complain of chest pain, and she came into A&E, and her heart rate went from about 80 to about 150. Her blood pressure went suddenly down, and her saturations, how much oxygen she was getting in, went from about 100%, about 98%, suddenly down to 80%. Does anybody know what it could be? Anybody know? It's something called a pulmonary embolus. It's a lung clot, which is incredibly. It's a lung clot, which is incredibly dangerous. And we knew she was incredibly unwell. We started to give her fluids, and then her heart stopped. And it was not a shockable rhythm. It stopped because her blood pressure was so low, and we couldn't get blood flowing into her lungs. And so the mum and the baby would have died. During the CPR, my colleague was running it. The obstetricians came down, and they did an incision just where you can see that gentleman's hand was holding to push the baby down. They did an incision. Obviously, that's not the patient. That's a mannequin. When we and did an incision to try and take the baby out, and we successfully took the baby out. The baby survived, and the mother survived. That's the wonders of modern medicine. Now, this is obviously a unique case. And I don't want you to think that A&E is like this all the time. It's not. It's very much not like this. Most of it is very different. I'm going to talk about different stuff. But this is sometimes you just get the most amazing cases where they survive. And this was one of them. On the 7th day of Christmas, my true love sent to me 7 scans are scanning, 6 mums are laying, 5 broken bones, 4 shocking pads, 3 broken ribs, 2 latex gloves, and a patient in A&E. These aren't all from me. I'm just going to show you some pictures of where some X-rays show the importance of scans. And this isn't, in Brighton we have a very cosmopolitan, different, very, very liberal population, and they come in with injuries which are often. It shows this as an old cassette tape. People aren't shocked that there's a foreign body there. They're shocked it's a cassette tape. Probably cassette tape. So this isn't my patient, I'd hasten to add, but just showing that there's some very odd things which can be found on X-ray. But I just want to talk about X-rays and about how great they can, be, but how dangerous they can be, and actually how as a consultant you can make mistakes just like anybody else. And this is a mistake that I made, which luckily was picked up by medical students, and just shows the importance of medical students, not just in learning, but in patient care. So I was looking out after an 85-year-old lady, and she'd fallen and hurt her hip. I thought it was going to be broken. And I looked at the X-ray, and the X-ray was completely normal. And so I told our medical student, can you please go and mobilize the patient, please? And they started to mobilize them. Oh, and I said to go and mobilize them. But we said, oh, can I just check first? And I'll have a look at the can I have a look at the X-ray? I said, yeah, of course, have a look at the X-ray. It's no problem. And he looked at the X-ray and said, Rob, and I think it's really, really important that all my medical students and junior doctors call me Rob, because when people start calling Dr. Galloway, that's when people are a bit scared or worried they can't ask you questions. He said, Rob, can I get you to have a look at the X-ray? And he showed me this X-ray, and it was the most obvious fractured hip ever. It's like, well, thank God you challenged me. Thank God you questioned my wisdom, because I was totally wrong. Does anybody know how I just missed it, or why I missed it? It wasn't even 3 a.m. I was just in all honesty, what happened is 3 weeks previously, they'd come in for an X-ray because they'd had no, I'd actually looked at the wrong X-ray. I'd looked at the wrong X-ray, because if I'd seen that X-ray, there's no way I'd have missed that fractured hip, because that is the most obvious fractured hip there is. It's on the, I won't use the annotate button because I'm scared of it, but it's on the left hand side. Okay. So what I had done is 3 weeks previously, she'd come in and she'd had a hip X-ray, and it was normal. And the X-ray hadn't been up, the new X-ray hadn't been uploaded yet. So when I was looking at what I thought was today's X-ray, I didn't look at the date or the time. And if I had, I'd have realized it was from 3 weeks ago. I looked at a normal X-ray from 3 weeks ago and said it's normal. And just shows that it doesn't matter who you are. It doesn't matter if I've been a consultant 11 years. I'm just as likely as anybody else to make a mistake. And it's quite common for other people to not notice obvious things here. You're much more likely to see this than a consultant radiologist, because the consultant radiologist, again, I don't want to use annotate because I'm scared, but the bottom left-hand side, as you're looking at it, there is a nodule, but we just don't notice things. Can anybody see what's up in the top right-hand corner? The little man, absolutely. Medicine's about seeing the wider picture. And I just want to show you, if you're managing a really complex situation, you've got to have systems in process to be able to see things which aren't obviously visible the whole time, and create these things such as patient safety checklists, flat hierarchy, that type of thing, to cope with the complexity. Because we're not designed to look after complex cardiac arrest or complex trauma. We're designed essentially to procreate and run away from woolly mammoths. I just want to show you a couple of videos about how, as humans, we make errors. Now, I want you to follow the instruction and type away the answer that you see. Okay, so follow the instructions, but follow it very closely. Hopefully you can see the video and hear it.
Here's a quick test of your powers of perception.
So if you...
There are 2 red files and 2 green files. Count how many times this red file is passed from one person to another in the next 20 seconds. Ready? Start counting.
God. Sorry. So how many did you get? Right. So we've got between 20 and 4. Right. So we've got E. Stevens said plus Danger Mouse. Okay. Can you be honest? Type away if you saw Danger Mouse. Sorry. Type if you saw. If you didn't see Danger Mouse, type me, please. Okay, so hundreds of people didn't see Danger Mouse. All the studies have shown that about 70% of us, when we're really concentrating, don't see Danger Mouse. Now, people will say, oh, I don't believe that wasn't there. Let me just play that again.
this giant mouse joined halfway through.
So that giant mouse joined halfway through. We don't notice things. So it's a human trait called inattention blindness, and we don't notice things. And so as doctors, we've got to make sure we try and notice everything. And that's why we need to have these safety check systems, standard operating procedures, working teams. So if you don't notice something when you're counting some files, you're not going to notice things when you miss some low saturations in a player, in a patient or something like that. So I just want to show you it's not just with not noticing things. It's about how we do our calculations, how we make sure we don't make simple mistakes. I just want to do this. This is a really simple question about, can you please count the number of Fs you can see? So that shouldn't be too difficult. Just count the number of Fs you can see. Okay. So just for those, comes after E, count Fs. So how many did you get? Type away how many you got. Right. So if you can all see the thing, the vast majority of you have said 5 or 3, 4, 2, and that wasn't difficult. This is counting the letter F. Counting the letter F, which is not a difficult challenge. Let me just show you how many there was. There was 6. Now only about 20% of people get that. Okay. And that's because we're human and we make mistakes. And so we need to help when we're working as doctors, we need to design out these mistakes we're prone to making. Okay. On the 8th day of Christmas, my true love said to me, 8 monitors are bleeping, 7 scans are scanning, 6 mums are laying, 5 broken bones, 4 shocking pads, 3 broken ribs, 2 latex gloves, and a patient in A&E. So these are some of the monitors we get. And I just want to talk about some of the problems about it. Is because you get something called monitor fatigue, where you just hear the bleeps all the time. The monitors by an A&E bedside are just called monitors, Helia. Just called monitors. They are, if they're just constantly bleeping, we'll sometimes just ignore it. But also, we may get fixated on something from a monitor. I just want to show you what happens when we get fixated, and what we can do is we can not believe some readings or get fixated on something else. And I just want to show you a non-clinical example of a fixation error.
When I bang my clipboard on the dash like so, I'd like you to imagine someone stepped in front of the car and execute an emergency stop, retaining full control of the vehicle. Okay. Would you please pull away when it is safe to do so?
That's a fixation error, which I thought was quite funny. I'm not sure if it works on the internet. But a fixation error where you're just fixated on one thing, and that happens in medicine all the time. We think, for example, in trauma, that we're going to have to go to theatre, but actually they may need blood first or something like that, and we get fixated on things. And it's really important that throughout a whole medical career, you be careful that you're likely to not notice the Fs, not be able to count, not be able to see danger mouse and get fixated on things. And then you can adapt your way of working so that you don't go down that mistake, because mistakes only don't happen because of a lack of knowledge. They happen because of a lack of human factors. On the 9th day of Christmas, my true love sent to me 9 boils are lancing, 8 monitors are bleeping, 7 scans are scanning, 6 mums are laying, 5 broken bones, 4 shocking pads, 3 broken ribs, 2 latex gloves, and a patient in A&E. This is something that's happened to me, which is quite disgusting. I went to see a patient who had a very large boil. I just pressed on it and it suddenly just flew straight into my face. One of the most disgusting things which haven't happened to me at work. But that's where we see things like boils and abscesses we see in the place called minors. And minors is the worstly named part of an A&E department, because you don't get minors injuries there. And also what may seem minor is often not. For example, a tendon injury. I remember seeing a tendon injury in a piano player. They were absolutely panicking. I didn't understand. It's like, look, it's just a tendon. we can suture. It gets take to the theatre. You're suturing. She was in floods of tears. I'd say, look, there's people whose family, are dying at the moment. Why are you so stressed? And she told me she was a professional pianist, and that was her whole livelihood and her whole life. And so you realise that one person's what looks minor actually isn't minor. So Healy, just in response to questions, you've got minors, you've got majors, and then you've got the resuscitation area. Resuscitation is the most sick patients go, and majors where everybody else goes, and then minors is like the walking wounded. And now we've obviously got COVID areas for all of it, so it's split in two again. And these minors areas, we often see things like mental health crisis, which is certainly not minor, but they are sitting down so they can go into that area. A cut to a face in me, I've got a face for radio. I've not got a beautiful face. If I got a cut on my face, who cares? But a cut on a face to a model will be treated very, very differently to a cut on a face of me. With a cut on a face of me, I just glue it up and I wouldn't care. I had a bit of a scar. So in a model, you get them sutured in theatre by plastic surgeons. But minors also, you can make mistakes. Now, I remember one Christmas when I was very tired, to be honest. I was a junior doctor, and I was, we don't see them so much now. The 95, 100-year-old war heroes, the real tough people. And I remember suturing up his knee, and I'd done about 5 sutures, and I was chatting away to him, and he goes, "Doc," and we got on brilliantly. He was like, "Doc, is it normal you don't use local anaesthetic anymore for injuries? I know they did that in the war, but I thought they'd developed local anaesthetic since. Why aren't you using it on me?" And I'd done 5 sutures without actually realizing that I hadn't used local anaesthetics. So you need to concentrate just as much in minors areas as in majors. On the 10th day of Christmas, my true love sent to me 10 pets are cheating, 9 boys are launching, 8 monitors are bleeping, 7 scans are scanning, 6 bombs are laying, 5 4 shocking birds, pads, 3 broken pens, 2 latex gloves, and a patient in A&E. So this was about an asthmatic patient. She it's a case I remember came in with asthma. Very good question, Naomi. How do you explain to the patient about mistake you've made? You just need to be very, very honest. And he could tell I've made a mistake because he was in pain. But you always need to be very honest. There's an asthmatic patient who'd come in very short of breath, and it was just about the reason why I want to talk about her is because she was in the waiting room. It was just because the triage nurse, the brilliant triage nurse who picked her up and realised how unwell she was, and we were all busy, and the nurse started all the treatments, started salbutamol, started all the nebulizers. If it hadn't been for that amazing nurse, that patient would have died. And it shows that A&E is about the teamwork. It's not about an individual consultant, individual doctor. It's about the teamwork that we all work within. On the 11th day of Christmas, my true love sent to me 10 deaths of cheating, 9 balls of lunch. I'm going to carry you get the idea. Ladies collapsing. This is what actually A&E is about. It's about it's about the elderly patient who's got multiple comorbidities. If you think you want to go into medicine to be the hero who jumps out of a helicopter and puts in a chest drain, I do that once every 3 months or whatever. I don't go in helicopters. I'm scared of heights and haven't yet done the HEMS job. But in terms of in A&E, in terms of doing that amazing, great life-saving intervention, that isn't that common. What is common is looking after the elderly who've got comorbidities, and it's about trying to do everything we can to stop them coming to hospital, to try and give them the best quality of life as possible. So we either get them out as quickly as possible, or try and get not treating is sometimes just as important as treating somebody. Okay. On the 12th day of Christmas, my true love sent to me 12 COVIDs, isolating, and then the rest. This is what we're facing at the moment. It has been a very, very, very difficult year. Working in very, very difficult conditions with a disease we don't know what it does, don't understand its physiology, its virology, but luckily there is hope. And I just want to leave this on a good note. We're hearing about what's the future, and tomorrow at 9:30, because I'm a frontline staff who's got I've got Crohn's and so I'm immunosuppressed, I'm going to get one of the first ever vaccines. So I'm very, very pleased and excited that I'm going to be getting that we're starting the vaccine program, and hopefully this isn't the end. This isn't the as Church said, this isn't the beginning of the end. It's just the end of the beginning, and hopefully this is the start when we can start moving on. So that's what just a pot puree of of what's been, you know, what I've seen in A&E over the last few years. What it's like the other 364 days. This isn't meant to be applied, but if you are interested, this is the book I wrote about what it's like working in A&E. It's probably, I wrote it 10 years, a few years ago. It's not very good, to be honest. There's lots of spelling mistakes still. It's pretty poor quality English, but it gives you an idea of what it's like. And you can get it whenever. Who's Dr. Nick Edwards? It's me. I've got two best mates. One's called Nick Reed and one's called Ian Edwards. And I thought Ian Reed would sound like a crap name. And so I chose Dr. Nick Edwards. So that's my book I wrote about what it's like to work in A&E, which will hopefully give you an idea of what it is like. But basically, I just want to say thank you for joining me. It's a great job. And if I can do it, then really, I think anybody can do it. And you don't need to have, you don't need to have gone to private school. You don't need to 9 A stars. You just need to be nice, hardworking, and a modicum of intelligence to, you do need to be quite clever to do it, but it's not, if you're really, really clever, you go into really high level science, being a scientist. In terms of, a large number of the population have got intelligence going to medicine. It's about hard work, dedication, and actually the one thing which makes a difference is being nice. And so I'd just like to say thank you very much for listening. Thank you very much to being part of this. And we've got, I think, a few minutes for questions, really. So if the adjudicators want to come in, we'll just try and go through some of the questions. So thank you very much.
Wonderful. Thank you so much, Rob.